Thank you, everyone, for coming for this chat today around inclusive leadership in healthcare. And I'll just call out the elephant in the room, right? I know there's been a lot of things in the media and a lot of things in the news right now around, cutbacks to DEI or in this. And really, I want to reframe this conversation, because really what I'm talking about is talking about what are those critical components of operational leadership effectiveness in healthcare, right? And it's interesting, and I'm going to share with you some of the data. There's some really neat, when I say neat, exciting research that's been worked on over the past couple of years, and that's going to be not even published yet. And I'm going to share some insights in that. But it's interesting that when you look at these critical components of operational leadership effectiveness, in healthcare, that it doesn't change. This is still at the core. The messaging hasn't changed. And so whatever we might want to call this, really what we're doing is we want to make sure that the folks delivering care can excel, and the folks that we're giving care to have equitable access to this care. So thank you for folks being here. So who am I? My name's Matteo. My pronouns are he, him. I'm the Senior Inclusive Leadership Facilitator, part of the faculty here for Diversio EDU. A bit about me. So I do have my clinical specialties in internal medicine, emergency medicine. I worked as a clinical instructor for many years. Although I have worked in healthcare, I've also worked in private equity, nonprofits. I've worked on several Olympic and Paralympic and World Cups. I've also taught at universities both here in Canada and the US, as well taught at Waseda University in Tokyo, Japan. That said, for me, I'm also on a journey with cancer. And so any opportunity I get to, wake up in the morning and spend time with wonderful folks like you, I really appreciate that. So thank you. And thank you for the messages coming in. I really appreciate that. So for anyone who doesn't know Diversio, they are really an amazing global leader in people and culture solutions, spanning in over 100 languages in over 51 countries around the world. And what I love about this, especially when I keep my clinician hat on, is that it's about making data-informed decisions, evidence-based practice. And that's really key and core at the heart of everything that we do. I realize that Zoom might not be net new for many people, but maybe what Zoom webinar might be. So just a few things just to highlight. There is a chat, and so I see the chat is getting lit up right now. So definitely use the chat. I don't think we have the raise hand feature, so definitely, you can use the chat, but as well, I'll be monitoring, and my colleague who's also here will be monitoring the Q&A. And if you need to, there's the closed captions as well, and that can show up for you to make it a little bit easier. Because I realize with my beard, for those that need a visual, I'm an older cisgendered white male with a shaved head and a very large beard and mustache, and I realize that sometimes that can prevent anyone who needs assistance. So why I encourage folks to turn on the closed captioning. So what's on tap for today? This is what we're going to talk about. We're going to talk about inclusive leadership. So I'll talk a little bit, broadly, what is inclusive leadership, and then what I want to talk about is it's a bit of a charged word right now, but bias in both patient care and in performance management. Right, when we're leading a team, what does that look like? And a term that I've been using for a while now, and I'm encouraging more leaders, agnostic to industry, but really in all industries, but especially in our industry, is taking that trauma-informed lens. Because at the end of the day, the folks that we lead in healthcare are professionals who are exposed to higher levels of trauma than other professions. And it's important that we take that trauma informed lens, not just in terms of, when we care for an individual, which is so important, but the people who are delivering the care that are also in our charge as leaders. We need to also apply that trauma-informed lens when we look at the work that we do. And of course, I want to make sure that there's lots of time for a Q&A. So I appreciate this, and I appreciate folks, and I love folks who are introducing themselves, and I love that building community by sharing their LinkedIn links as well. So let's get right into it. One of the things I love is live polling. One of the things I love about the live polling, it's completely anonymous. It's a really great way to help encourage thinking about inclusion from, all aspects of dimensions of diversity, including those aspects that might not be visible, including things like neurodiversity. And because often folks like me, who are the loudest in the room, are the ones that often get heard the most. And so what I like about the live polling is it really evens the playing field. So we're going to start off to get there. You can scan the QR code, or you can go to polv.com/IDMS. And I see that's dropped in the chat as well. And I've got a few questions today to get us started. The first question is a nice and easy one. You can just click on this image, but I'm just curious, how are you feeling today? I think this is a really great one, especially for anyone who's familiar with inclusive leadership. We know one of the biggest critical components of operational leadership effectiveness is psychological safety, creating, a safer, braver, and accountable space. So I always like to ask this, and I see we've got, no, I only asked or put a 5-point Likert scale with a bunch of, happy faces or sad faces. Somewhere in between, I see, we've got a distribution here. No one in the red yet, and that's okay. And I don't want to put anyone in the spot, but we're also seeing some folks in the orange, yellow, light green, and a darker green. So thank you for that. I really appreciate this. And that, okay. So, and so I just want to honor in the space that folks are at right now. So taking a look at the next question, I'm going to just ask. I see we've got 23 respondents. So thank you for folks responding. Let's get into the meat of it. We know why we're here today. And that is, what is the biggest barrier to achieving inclusivity in your healthcare organization? So if you're, part of, a hospital or part of a health organization, or you're delivering care for patients. And this one, I got the QR code here. I'm just going to move the QR code so we can see the responses coming in. But the QR code, just if you need it, is up at the top right-hand corner. And so interesting, I'm seeing bias. So thank you for that. Yeah, closed-mindedness, definitely. A lot of assumptions. When I started my career, don't want to age myself, but for any American, Reagan was president when I started my career, right? And those things that we did back then, certainly very different as leaders that we need to do in order to be successful today. So I'm seeing buy-in, definitely changing the mindset. So I'm seeing a through line here with bias coming in. It's interesting, differing political views. And it's interesting, again, as a clinician, I'm like, does the political view matter? At the end of the day, what we want to make sure is that we're delivering the top care, and that the folks delivering the care feel supported, can thrive, and can truly move forward. So thank you. And thank you for folks continuing to introduce themselves on LinkedIn. But I'm loving this: government policy, lack of DEI education, tactical approval of the status quo, highest levels of leadership, knowledge gaps. Got that old way of thinking. I certainly remember the way things used to be, and the more that going back and working as well outside of my job here at Diversio, I'm seeing, how things have really changed and shifted, especially in some of the, larger acute care sites where, the issues haven't really changed, especially the leadership issues. It's still quite the same. Yeah, ignorance and stigma. Just maybe how we deliver the care, maybe some of the medications that we're offering, some of the lab tests have maybe changed. But it's interesting, there's certainly some through lines happening here. So again, thank you for folks for doing this. What I want to do is just spend some time, and I never want to assume that everyone's at the same page or has the same definitions of inclusive leadership. So what I want to do is just take a look at, what are some definitions, or how people have looked at inclusive leadership, especially within a healthcare context. And one of the ones that I really, really love, and it was a study that was released, I know it's almost, 9 years now, but back in 2016, our good friends at Deloitte looked at not just healthcare, but healthcare was certainly a component of it, but they looked at industries, and then they didn't look at just North America or just Canada, they looked globally. And what they looked at was, what were those, and they called them traits, but what were those key traits of an inclusive leader? Those leaders that had high performing, high thriving, high inclusive teams. What were those commonalities? What were those threads? And they tried to codify those behaviors of those inclusive leaders. And I'll just share just high level, a quick summary of what those 6 traits were. And they looked at things like commitment. So a commitment to a diverse workplace. They looked at courage, but with both humility and bravery, because often, courage is one of those words that can have, different meanings depending on people's lived experiences and people's different perceptual lenses. But it was really a balance between both humility and bravery as a leader. The other one was being curious, right? And being comfortable with the uncomfortable, the unknown, the uncertainty. And that was an interesting trait, right? Is how that leader can be genuinely curious. As well at the same time, humble and brave, as well committed. The other one too was, collaboration, how that leader set the table for teaming and voicing, how that leader set the table for folks, again, to enable that psychologically safe, or at least safer, braver, and accountable space. Now, Dr. Bork use the term cognizance, but Dr. Bork was referring to, which he was referring to, is cognizance of bias, which is interesting because on the previous slide that we talked about, bias I saw multiple times come through, and what Dr. Bork and the research team found was that those leaders that spent time on that self-reflection, spent time understanding not only their own bias, but also the systemic biases that might exist in their organization, and spent time thinking about that, had more success as an inclusive leader. And it was interesting because one of the interesting notes that Dr. Bork noted in her research was that having best intentions didn't necessarily equate to inclusive success, right? Because we can have the best of intention, but doesn't mean that our best intentions land with the impact that we may have intended. And the last but not least, and this is just because I had to put in some type of order on this PowerPoint slide, was cultural intelligence or cultural competence. And understanding, what led, when you're looking at a problem or an issue, what led to you, whether it was your upbringing, your culture, to understand, but also understand that someone else might have a very different perspective or perceptual lens based upon their culture. And often too, one of the callouts that Dr. Bork and her team made was often, when we think about culture, we default automatically to think about, different culture based on race, ethnicity, or country of origin, which is very important, don't get me wrong. But what they also indicated is that when you have folks coming from different organizations and coming from different areas, different departments, different hospitals, or maybe even different industries, they're going to have a different work culture, a different way of completing tasks, a different way of, communicating, building relationships, or how they might value building relationships, how they might handle conflict and conflict resolution. And an inclusive leader was able to adapt to the cultural context, but understand that cultural context was more than just country of origin, but it was also could be different areas. And perfect example for me is I started my career, my first 6 months. I worked emerge in downtown Toronto, one of the busiest emergency rooms ever. And then after about 6 months, they floated me to pediatric psych. And that was the hardest thing I ever did in my life because I couldn't adapt to the work culture in pediatric psych. Because in emergency, it was literally go, 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 go. What do I need to know? Who's my next patient? What needs to happen next? And I didn't care what the nurse's name was, or the physician's name. Like I was so hyper focused on the task. But in pediatric psych, they wanted to get to know me. They wanted to know me and my, who I was dating and what, TV shows I was been watching. And that was so off-putting for me because I couldn't adapt to the different culture. But when you think about it, in psych or even in pediatric psych, where the patients are there not just for a few hours, but for months, sometimes weeks, or if not months, that task completion, relationship building, had a different cultural lens based upon the work culture. And so it's important for us to balance that as well. So interesting. I want to share, there's some really interesting research now coming or going to be, I believe, published this spring from Dr. Ravier from Queen's University that looked at what were those key components of operational leadership effectiveness for what she determined trauma-exposed professionals, right? So those professions that are exposed to higher levels of trauma than others, right? And the definition of trauma, I know that can be, again, one of those things that has different definitions, but what they looked at here was, exposure to human suffering, which we know in healthcare, we are. And so what she looked at was 3 professions in particular from a Canadian context. And she looked at nursing, firefighting, and military. Again, 3 professions that all have higher levels of those professionals being exposed to trauma. And I'll just quickly go through some of the stuff that when she does publish, I hope, I think it was March or April that she was looking to publish. I just got to be a part, and I know if they're still in that verify and validating as it's getting peer reviewed at the moment. But what they looked at was, the leaders needed to have, or to be able to show care and support. right? So this is not going to be groundbreaking or like, oh, but for many of us, we're going to go, yeah, that makes sense. But that was one of those critical components for an inclusive leader. Humility came up, listening and empowering. I mean, again, through lines here, ongoing feedback, right? So this need for a feedback-rich, feedback-safe environment. Role modeling was so important, right? They needed trauma-exposed professionals needed their leaders to role model the behaviors. Knowing your team, right? So this became out really important. That really understanding the motivations of the team, understanding, what were those critical things that were important to those team members. That was clear in our research, and not just in healthcare, like not just in nursing, but also in these other professions, being available and approachable, which I know this is hard, right? I've managed nursing units before, and I know it can be hard to always make sure that you or somebody is available and approachable. And these behaviors around what the leader did to help unify the team, and clarity of operational directions. And so these were the key things. And so I'm encouraging folks to really, when this research does come out, and there's some research that she's released previously, because this is, of course, has been really important. And she looked in the study that's in the chat is around the policing. But when her research gets out later this spring or sometime this year, I encourage you to take a look at it. What I want to do now is just share some examples of some lived realities. When we look at the data, when we look at, the folks that we're leading, the folks that we are caring for, that are in our care, what's their lived reality? Because no matter what's happening, what's out there in terms of the media, in terms of what they're saying, in terms of this, we have to understand that for many human beings, their lived experience is significantly different and what the data is clearly saying, if they look different than me, right? I'm an old cisgendered white male. I have a very different lived experience than others. And it's clear that, to us LGBTQI plus individuals, and we've got the studies on this from just a few years ago, frequently face healthcare barriers, resulting in worse overall health outcomes, right? And we can certainly share this data with you, but these are, again, all sources that are available. We know racialized patients experience disproportionately higher rates of negative healthcare interactions. And in particular, we were looking at some data in the US that individuals who identify as Black and Hispanic patients were more likely than white patients to report that healthcare providers refused to order necessary tests that the patients felt they needed, right? And that there was a disparity there between the lived experiences of white Caucasian patients versus racialized patients. And we know, though, too, and there's some really interesting data here around organizations that have this commitment to diversity outperform financially and demonstrate higher employee retention through improved inclusion and equity practices. And I'm going to give you some very, very specific examples from my lived experience. And this is, again, from my lived experience. And I understand, too, as I go through this, I'm going to share some very specific examples. And I'm not going to specifically say this was the hospital or the healthcare system I worked at, or this was the patient care information system. I don't want this to be a litigation of that system or of that team, but more as a call to action for us in this field of things that we need to be mindful of. When we move forward with new initiatives, when we move forward with adopting something, that we can't just say, oh, everyone gets along, so therefore everything is good. That we need to be mindful of certain things. I'm going to share some stories. So, first thing I'm going to share is I'm of an age where I remember, if I needed a patient file and I went to the nurse's station, I remember my very first charge nurse, she always had a cigarette in her mouth that was dangling. And I think the ash that was dangling from her cigarette was always longer than the actual cigarette, and when I get the patient chart, I have to always and I was like 20 in my early 20s, and I'm coughing while I'm going to I hated going to the nurse's station because I had to, remove so much ash there. Now, how things have changed now, when we need a patient's chart. I remember when these first came out, I was working in Calgary many, many years ago, and we called them cows, a computer on wheels. But I want to talk about something specific. So, and this was not back in the day, right? Not back 20, 30, 40 years ago, but this is recent, within even just a few months ago. where I was working Emerge, and uh, we had a car accident come in, and two patients presented. And I wasn't there for the initial assessment, but I was there to help supervise and I came in after the fact. But what had happened is these two patients, again, similar, two males, similar age, similar, body mass index, similar size, also very similar injuries, were in the trauma bay, side by side. And of course, the doctor ordered a pain protocol very, very quickly to get it done. But what I need to set up is that this healthcare system had brought in a new patient care information system. I remember Meditech back in the day, right? And even before that, when we were all 100% paper. But this new patient care information system had this wonderful AI that was supposed to make, and it's still framed as to make it easier and quicker, especially for those in Emerge, to be able to move quickly. And anyway, so I wasn't there for the first part, but when I was there, and I saw, and it was again a young nurse, and I saw that she was hanging the pain protocol. She was hanging the morphine, and I kind of looked, and I was like, why is the injuries are the same? Why is one bag like it was significantly titrated? It was significantly lower dose than the other patient. And there's just like, I don't know, this is what the doctor ordered. And so I went, found the resident and the attending, and I was going to get mad. I was like, why is this one person getting significantly less? And they're like, what do you mean? They had no idea either. And we're trying to figure out what it was. And so what it was when the admitting clerk, and I'm not blaming the admitting clerk here, but when the admitting clerk comes in, they have to, by a visual cue, because we might not have access to, to their health card, picked, because there's a drop down on race, and they had to pick, a race or ethnicity. And so one of the patients had darker skin pigmentation than the other, and so the admitting clerk selected black, and the other one selected white. And so when we looked at this and we tried to figure out, why in the admitting order set was the one pain protocol significantly lower than the other, what had happened was that the system automatically titrated lower based on race. Even though that wasn't the physician's intention, that wasn't what needed to happen, that wasn't what was clinically indicated, but because of this AI. And I've got another story because this happened very quickly. And ignore the picture for now because I have another story about that as well. But we had an 8-year-old boy who happened to be Indigenous, First Nations, present with a green stick fracture to his left arm. Very common injury we see in Emerge all the time, especially with young children, falling with their bikes or jumping off of trampolines or whatever, right? And so again, I wasn't there for the initial assessment, but when I came by, I noticed that the nurse was drawing blood, and I was like, what you doing? And I, pulled her aside and was like, what's happening here? And she goes, oh, I'm drawing blood because the doctor ordered an A1C and a blood alcohol consumption test. An A1C is for diabetes and a BAC is to understand, how the level of alcohol. And I'm like, why would you do that? He's 8 years old. Are you suspecting diabetes? Why is this, I'm trying to understand this. And so again, I went, grabbed the resident, and I was like, what are you doing here? Like, in the attending, I'm like, what's happening here? And they're like, we didn't order these tests. So again, this exact same thing happened the previous, right? So as soon as the admitting clerk picked Indigenous First Nations, automatically the AI added the A1C and the blood alcohol consumption test automatically to that admitting order set. Not that it was clinically indicated, but because of the way they picked the race. And so when we did more of our testing, because I was also part of the team that helped test this new client, we spent 6 months testing, and we were trying to understand what went wrong. And we're like, we tested this. We went through like almost hundreds of scenarios, looking at different order sets and different things. We were testing, of course, to make sure, the process flowed. The communication went to the lab, the communication went to pharmacy, the communication that needed to be fired off went. But what we didn't realize, because when we looked at, again, all the order sets or all the testing that we were doing, because we spent 6 months testing the system before we went live. Not only were all the testers, the people who were parting the clinical adoption team, looked like me. I'm not saying there's anything necessarily wrong with this, but we didn't call this out. And then what we didn't realize is that we never once in any of our examples over those 6 months changed the race or ethnicity of the patient that we were treating. And so I share that because again, we had the best of intention here, right? Using this AI again, not realizing that the AI had these biases present. But let's call out this picture, right? This picture, even I used AI for these images in this presentation, and I was so frustrated the other day when I was putting this through because my first prompt that I put into the AI was, give me an image of an 8-year-old boy in a hospital setting with a broken arm getting his blood drawn. That was the first thing I asked, and then I kept, no, you're getting it wrong because the first couple of images, I mean, it was like with a First Nations Indigenous headdress and other, very stereotypical. Where that and not and so I ended up having to go, okay, please make the young boy with just slightly darker skin pigmentation. But then also I couldn't get the nurse. I kept saying, drawing blood, and couldn't get it right every single time, even though I said do it on the arm that's not injured. Always had the nurse drawing the blood through the cast. So again, it just shows that we need to be more cognizant, as we and I love this adaptation, adopting of new technology and new stuff, but we have to be mindful. I've just given 3 very specific examples of, a racialized patient experiencing a very different titrated pain protocol, or an Indigenous boy receiving unnecessary medical, or even trying to find an image to do this presentation today, where unfortunately bias is impacted by this new systems that we're using. And we know too, and I see this across Canada and in the US as well, and the clients I speak to in the UK, we've really relied on foreign trained professionals to come in, right? Whether that's nurses from the Philippines or other professions, from different areas. And yet, have we set the table for folks to truly feel that they're included, to truly feel that they can thrive? And the one example I'll give is very specific example is there was this hospital in Denver that had this issue where they had a nurse, and I'm not going to say her name, but this nurse was an immigrant to the U.S., immigrated, I believe, from Mali about 12 years ago. English was her third of 4 languages, was also part of the 2S LGBTQ plus community. But one day on her way to work, she took the bus in downtown Denver. And you can Google this. This happened. And I don't know if they caught the person, but somebody in Denver created these professionally looking signs that said, Kamala's immigrants to the back of the bus, or something like, blacks to the back of the bus. So of course, this nurse who's on her way to work sees this and is quite upset, right? Quite, I understand that. And I certainly prescribed as a leader myself that, we leave our trauma at the door, we leave our politics at the door. When we show up and we do what we need to do. However, this nurse, obviously comes in looking probably a bit distraught, was maybe in the back room, and one of her colleagues sees her, and what they said was, oh, there she goes again, being the difficult Black woman. So now she's not only experienced, very, very racist behavior out in the community on her way to work, now even from a colleague experiencing this microaggression that wasn't addressed by anybody in the room. And then her very first patient assignment, the patient refused her care because of her noticeable accent and probably because of the assumed race. And so stories like this, unfortunately, I keep hearing time and time again. But what I'm not hearing, and this is interesting because this happened at that health system in Denver, was the initial patient care manager of that nurse was just like, look, what can I do, right? This happened outside, right? And the hospital administration, they're like, well, this happened outside. Then let the Denver police happen. When that nurse comes in, they've got to show up. However, what is our role as inclusive leaders? To set the table for that nurse, right? Or for foreign trained nurses who are experiencing these levels. And we use the term microaggression because that was, what Dr. Chester Pierce first published in 1970 about microaggressions. But let's call it out. Microaggressions right now, this is disrespectful behavior, right? And this is not just out in the community, but it's impacting. But even so, even when folks from equity denied, historically equity denied communities are experiencing these levels of additional trauma, whether it's out in the community or it's from their colleagues or from their patients. My question is, what is our role as leaders in this? And especially if we want to have the top best talent, we want people not only just to be able to show up and not just fit in or code switch, but to truly thrive in their roles. What role do we have? And I know there's lots of stuff happening in the chat. My apologies. My vision is kind of bad right now because of this round of chemo I'm on. So I will get back to these in just a second. So thank you for some wonderful questions coming in and messages coming in. So I want to talk about, okay, so what's now what? And there's a book I love, and it's been around for a while. It's from the book Destroying Sanctuary, which some people might be familiar with. But sanctuary, what Dr. Silver was talking about in sanctuary trauma was the psychological traumatic events that occur when someone faces a severe stressor, then discovers more trauma when they return to what was expected to be a supportive and protective environment. And also, you might have heard the term institutional betrayal. Refers to institutions, which can include, healthcare systems, causing harms to those who depend on the institutions. Clinical and allied health professionals, residents, for example. And so one of the asks I have is, okay, so what's our now what? How are we going to move forward? Understanding that this sanctuary trauma, this institutional behavior, unfortunately is still continuing today. What is our now what? And so what I'm proposing is that we take, this lens of inclusive leadership to what we're doing, because at the end of the day, we are still going to have this occur. And one of the examples, and the reason why I think I still do what I'm doing right now is I'll just call this out. It was quite a few years ago now, but back in 2003, I was at Sunnybrook in downtown Toronto. And for those who know the history of 2003 and Toronto knows that's when SARS, right? So I like to think that it's the pre-COVID, if you will. And I lost quite a few, four. Two were roommates of mine and four were, and the other two were, all of them very dear friends of mine. And, we lost them to, what was called atypical pneumonia, but we were all in our 20s. Or early 30s, then all relatively hell with no previous conditions. But was interesting, when SARS first hit at Sunnybrook and all the hospitals in Toronto that were impacted, we needed to get the N95 respirators in, but there was a shortage because we were burning through them very quickly, not only after the first round of outbreak, but also in the second outbreak that occurred in Toronto. And so, and I don't blame purchasing for this, that purchasing needed to get more respirators into the hospital quickly. And so, and then being in Ontario, trying to find, a supplier that could supply at the rate that we needed it, found some, and if you're familiar with Ontario also is really well known for, large manufacturing and mining industry. So there was a plethora of these N95 respirators or the masks, and we weren't doing respirator fit testing then. And what had happened, after investigation, once we started doing respirator fit testing, the old where you put the mask on, then put the hood on, and then we'd spray the Vitrix in. What we found was that those masks that we were purchasing were designed for people who worked in manufacturing and mining. Now, at that time, who was the dominant group that worked in manufacturing and mining? Folks that had bone structure similar to me, right? It was typically men. And white men. That said, who was the primary, nurses and those allied health professionals who were working at Sunnybrook then and still now to today. And so we had a very different bone structure. And so those respirators did not fit. Again, that wasn't an intentional miss, but it was a miss because we didn't have, inclusive leadership at top of mind. We were so focused on just getting what needed to get done, not we're resetting the table where folks can truly thrive. And so now as we move forward, these are the types of lenses that I'm encouraging us now, because not just for psychological injuries, which is so important, but also from the lens of, making sure that we've got a safe place, right? And so one of the things that's going to come out in the research around inclusive leadership for trauma-exposed professionals was what we need to do to create sanctuaries for trauma-exposed professionals. What are those things? And there's a lot of dialogue now happening. Right now, if anyone, and I know I'm not in Ontario right now, but one of the kudos to Ontario Health is they've released a new, not new, but they've released a new anti-racism and reconciliation framework that's now being mandated for all hospital systems in Ontario to be using, right? And part of this includes a call for these, what they're calling sanctuaries. And what that look like will be different, depending on, whether it's care, emergent care, and, where these are. But this path to get there is going to require us as leaders to be directly involved. Right. This is not going to be just, you belong kind of statements or a pizza party. This is going to be some longer term discussions that are needing to be happening to be able to create these sanctuaries moving forward. Other things that came up as well was this curation of a safe, and I put in brackets safer because it's never going to be safe for everybody, but safer places for rest and digest. And that's important. And that's something too, I find too, especially now, I'm saying in my 50s and as I get older, but this ability now to really rest and digest. Back in my day, when we, especially working in Emerge, when we had, I remember a bus spilled over with all young children came in, and that was I was in tears, but I never cried in front of my peers, in front of my colleagues. I waited till I got home until I broke down and cried in the bathtub, and I didn't get out of the bathtub for hours. But that's not necessarily a safer space. And so how can we create these safer spaces for our folks to be able to rest and digest, right? To be able to process this. Other things that came up is how, and this certainly come up, and I've seen this time and time again, is how do we build this knowledge and skills for stress and trauma awareness, for emotional regulation, for communication and relationship management. These are going to be things that we need to be building even bigger into these systems, for our folks that are in care. The other thing too that came up, and I thought this was interesting, and again, it's pulling up a model from a few years ago, and hopefully many are familiar with this, but it's this notion of intersectionality, and where the researchers were going is that we need to take an intersectional approach to this. This can't be it's a one size fits all. So I know the example I talked about, with the SARS, but we took this one size fits all approach to N95 respirators, and the impact was, I lost, several of my colleagues to atypical pneumonia, aka SARS, because we didn't take an intersectional approach to leadership, whether that's in purchasing, whether that's understanding the intersectionality of even bringing in a new patient care information system with this awesome new AI that all the kids are using now, and not realizing that without this intersectional lens approach, that we could have unintended, very negative consequences, both from a patient care outcome, but as well for the folks that we're leading, the folks that are in charge of delivering this care. And so when we look at trauma-informed leadership, there's some key elements here I just wanted to touch on, but this prioritizing of psychological safety. And this one we need, how do we foster these environments where both staff and patients feel safe, respected, and supported? And this becomes harder, right? I had an incident where a patient care manager that I've worked with contacted me because one of the clinicians was doing, and I don't know how to correctly say this, but was doing the Elon Musk salute on the ward, on the unit, in front of patients, in front of other staff. And the first reaction was, well, how, do we fire this person? Do we, what do we do? Send it to the union for review, or do we, just accept this behavior because we can't afford to lose any more staff? And these are the kind of things that are happening today. Like, this literally was Monday of this week. So what are we, Thursday? This was just 4 days ago. And so these are the kind of things that leaders now are dealing with. And the fact that I'm hearing from hospital administrators and leaders is, what do we do? How do we create psychological safety when these behaviors are running rampant? And so whether it's as intentional as that probably was, or I'm assuming was, or it's these unintended things, these are having very direct impacts. And so a big part of this, and when we look again at those critical components of operational leadership effectiveness, uh, promoting empathy and resilience isn't a bad thing. I know it's getting a bit of a red mark right now in the media, but this, understanding how trauma affects individuals and how leaders can support staff with empathetic engagement and flexibility, this is going to be huge for us, one that we can't just ignore. And so I've got a few questions that I'm going to propose, and I shouldn't say these are not mine. These are actually that are going to be, that's part from the research that Queen's is doing that is encouraging leaders that want to become more consciously inclusive. It's not just to say, I'm consciously inclusive, everyone's welcome, everyone's can thrive, that there's questions in terms of self-reflection that we need to take. And so one question is, am I truly listening to others, or am I focused on responding? And this, we feel, can help leaders tune into active listening and value others' perspectives. Another question, what impact am I having on those around me? Am I fostering growth or limiting it? And what we hope is that this will encourage awareness of their influence and role in others' development. And oftentimes it's very quick when we're operational to forget that. Am I aligning my actions with my core values and the values of our organization? And this can help leaders really ensure their actions reflect their authentic selves and organizational purpose. What assumptions might I be holding that limit my ability to lead with empathy and openness? And I think this is a powerful one, because this can really, especially if you take that time to really unpack, can promote, challenging biases and being open to new ways of seeing situations. Everyone's excited about the new shiny patient care information system, right? But have we take a look at what assumptions we may be making? Are we taking an intersectional trauma-informed lens approach to this? Am I balancing my own well-being with my responsibilities so I can lead effectively? And I think that this question, it was really powerful, because when I asked that patient care information manager, or that patient care manager that asked me that question on Monday about that, one nurse who was giving that salute, and I just said, how about you? How are you doing right now? How can I make your busy less busy? And these are, again, questions. And so one of the things I encourage folks to do, and we have a lot of not only data, but very specific things around the building blocks of psychological safety. And thank you. And Dan, my colleagues already shared it in the chat. If you're not familiar with this document, I highly recommend. It's a really great called Assembling the Pieces for Psychological Safety. It's a PDF that's just been shared. And it's really one that I encourage folks to come in. And I know when this came out several years ago, oftentimes people go, oh yeah, we're psychologically safe, but they never verified and validated that it truly was for folks. And so I just want to, before I jump in to answer some of the questions in the Q&A, and my apologies if I missed questions in the chat, I'll just ask my colleague to make sure that I answer this, but I'll definitely want to stay on. But one of the questions I definitely want to hit on, well, not question, but a quote, and I love it. It's from Dr. Paul Brown. Been around for a while now, but I really like where Dr. Brown was going with this. But good leaders are those who know how to manage the flow of energy within their organization. Unfortunately, a lot of these leadership approaches continue to embrace a 19th century mechanistic model of optimizing output. And I'm certainly guilty of that myself as well. And this approach does not engage human energy in an effective way, since human beings are infinitely more than machines, right? And we have to understand, we come with a lot of emotions, we come with a lot of trauma. And how do we pivot to become more consciously inclusive? I think it's going to take a lot more work than just good intentions. So thank you. I want to thank you. So I'm going to definitely get into questions. I'd love to know, I love this question, what area of inclusive leadership in healthcare would you like more training on? So if you need the QR code, I'll just move it into the corner. And I'm going to take a look at the Q&A now. And I see that we've got some coming up in the Q&A. And I ask if you do have questions and I've missed it, please put it into the Q&A, because I can make the Q&A box bigger. I might have missed something in the chat. So one from an anonymous attendee: what are some techniques for clinical staff to employ when they experience bias related to their heritage, age, and position? That's a great question. So I think even before I answer the techniques for those clinical staff, the challenge I have for the board and for the senior leadership is how we set the table where we can call in and call out these behaviors where it's not a hand slap, a finger point, or a blame shame game, but this is a critical component for the success of our operations. And often when I talk to the board and senior leadership of many of these health systems, they haven't done that. So that I think is critical to happen first. And then what needs to happen is do folks have the tool to be able to call in and call out? If someone is being called in and called out, do they have the tools necessary to be able to own that, acknowledge it, and know it's not about them as behavior, or no, not it's not them personally, but it's about behavior. But if we can't get there, if we haven't set that table, um, we can put all the processes in place, but then every time someone who comes from a global majority but historically equity-united community calls out, hey, look at, I'm dealing with a lot of racism here, or sexism, or homophobia, or transphobia, or I'm dealing with this a lot of othering on my team. And we don't have the skill set to call in and the skill set to be called out. And we don't have those systems in place, which again has to come from the leadership to be able to set that and make that a priority. Not just buy the most expensive cows, computer on wheels, but to get us that type of level of, and I don't see this as soft skills training. I definitely see this as critical success. When I look at, nursing schools and med schools and other professional bodies, this often is not a critical skill that's taught, learned, and maintained in one's career. And this I think really needs to be a priority. So hopefully that helps. But again, one of the techniques I would recommend is spending some time understanding how to call in and call out. And there's a wonderful book, and I can't remember her name. It's called Calling In, and it's by a professor down at Howard University. I can tell you exactly what she looks like, but I can't tell you what her name is. But it's called, and it's not being released until February 4th. I'm excited because I've got it on pre-order. And it's coming out February 4th. I will, if you give me a second, but in that book, she's got a lot of great, and it's based on over 40 years. But it really sets the table for how to call in and call out. So hopefully I got to answer that one. So how do you talk about gender, sexuality, and race Dara, I wish I knew that answer. I wish I do. And often, we're not in a place where, we can necessarily change the lived values. And I don't mean to make stereotypes of, those folks with age-associated memory impairment or dementia. But let's be fair that, there's different lived values there. And also when you get into dementia, I mean, even just getting them to, put on their slippers properly or to even, properly vacate their bowels, in the proper place, those become concerns. And so these are stuff I wish I had the answer for that. But if someone does have the answer, we need to have a group, because I don't think, especially, and again, that wasn't my senior care wasn't my focus, but we'd experienced that in Emerge all the time and in internal medicine. But I don't think that I have the best answer for that. How can we prevent team burnout? With folks with varying abilities, verbal and nonverbal. And I think this is one that we need. And again, of course, the magic wand would be just hire more folks, open up. I believe I saw that there's more medical schools being opened in Canada, here in BC and Ontario, and we need to have more folks coming into the profession for sure. But there are, in lieu of just hiring more, right? We know hiring is so difficult, but there's other things that we can do and we can focus on, and that's what I'm going to encourage is find ways. And it's not going to be the same. I know when I was working in the Calgary Health Region, which I think it's now called Alberta Health, but when I was at the Foothills Medical Center in Calgary, and I had an office at the Rocky View as well as Peter Lougheed, all acute care adult sites. I used to take my staff to Dave & Buster's. I don't even know if Dave & Buster's even around anymore. I don't know, right? And that used to be where I thought we could rest and digest, right? And of course, that didn't work. It worked for me because as a male, I didn't have, childcare or caregiver responsibilities, but that didn't work for many of the people on my team who had childcare responsibilities or who didn't want to necessarily hang out with their colleagues after work. They spent a 12-hour shift with them 4 or 5 days a week. And so finding something that works for the team, I think, is so important. How to manage the back. It's interesting how to manage the backlash towards DEI. I wish this is something the team here, and my colleagues at Diversio are looking at. In fact, we actually have a webinar coming up on, I believe, February 13th, but I know it's going to be dropped into the chat in just a second. But it's going to be a roundtable discussion, very highlighted on this. This is coming up. I have clients, in the Foreign Service as well, the U.S. State Department, and they're facing backlash. I mean, many of them, have either been fired or have been let go, and we're seeing this backlash. And that example of that nurse, and this was not in the U.S., this was in Canada, where a clinical professional decided to give I won't do it here, but that salute, which is completely appropriate on Monday, which was also the 80th anniversary of the Holocaust Memorial. And so we need to, in terms of this, I guess this is in my own personal opinion. I know they'll have much more eloquently spoken folks on the 13th describing this, but part of me feels we need to draw a line in the sand. And these are our core values, racism, sexism, misogyny, and I see this coming up here, keeps coming up, and what is acceptable, as clinical professionals, what is acceptable, right? And if we are going to hold, the folks that are cleaning the rooms to a certain standard, we need to hold everyone to the same standards as well. And so if you're interested in that roundtable on merit, culture, and equity, I always hear people talk about merit, and I'm like, yeah, if we treat everyone the same, I've got so many examples where that just doesn't work, right? And the same thing, if we were just to rely on AI alone or just patient care information systems, plethora of examples of where that's not enough. We need to really be mindful of the fact that humans are different, and how do we set the table for everyone to truly thrive, and not just get by as they're getting by. So I'm seeing things, racism from patients. This is unfortunately, racism from coworkers to patients. These are all things that need to be dealt with, right? And what is that code of conduct? Cultural safety, working with different cultures, and understanding. There's a lot of great tools around. So we're hitting on this one, a lot of great tools out there around not only becoming more self-aware of someone's own cultural competency, but also developing a plan. It's called the IDI, one of the things that we actually offer here at Diversio, that measures one's own cultural competence and then gives you a 6-month plan to develop your own have a game plan to develop your own cultural competence and use that as a skill set, because this is clear from the research that cultural intelligence, cultural competency is a critical component of inclusive leadership, and yet often gets missed. It's very similar to like DISC or HBDI or Myers-Briggs, but it's hyper-focused on understanding culture. Again, culture, not just in culture of race, ethnicity, country of origin, but also, varying levels of culture, work culture, department culture. Peer hypervigilance, over policing of race, tools to help differentiate between emotions that belong to me and emotions that belong to unsafe environment. And I think I might know what this individual is meaning, but we need to develop more tools. One, become more self-aware, but also two, that ability to to regulate not only our emotions, but also understanding the emotive state. And as leaders, we control, and I say we control, let me reframe that. We have a lot of influence, us and our teams. And whether you have a leader in your title or not, the ability to control or help influence anyway, the emotions around us. And we need to be able to navigate that. Hopefully that has helped folks. I don't think this is ever a once and done, or that I'd say, here's the magic bullet and run, but really this is an opportunity. This is always going to be ongoing. And my encouragement is to not stop. Even though, regardless of what might be happening, politically or anywhere else, that this is important work. And not just because it's a warm, fuzzy, hug trees, sing kumbaya, and kiss puppies, but this is important if our mission is to truly deliver on delivering the top care for everyone and respect for humans, not because of positionality, not because of achievement, but because simply they're human. Thank you so much, everyone, for this conversation, and I'm wishing everyone all the best.